they would come together, they would discuss their, do we have okay. They would come together and discuss their medical issues, and they would influence each other's behavior. And so I sort of observed that this diabetes problem was inherently a social problem, especially in the very, very, very social Middle East culture where everybody knows everybody's business and everybody does everything together. And I'm sure you could think of many other places in the world where this similar thing may apply. And the thought was that if this were true, if in a sense diabetes was spreading like a virus, like a contagious disease, from family to family, from parents to their children, not in a biological sense of infection, but in a social sense of infection, then the reverse might also be true. And looking at some work that later came out of Harvard, Nicholas Christakis and James Fowler, indeed there were studies that suggested that over a 30-year period, obesity actually spread like a disease through networks. Alcoholism could spread through networks. Smoking behaviors could spread through networks. And in a sense, this is cutting-edge epidemiology, and another, this is sort of Stone Age, observations. People have known since the dawn of civilization about peer pressure. But I think where we as researchers and practitioners need to really kind of think more deeply is about the specific nudges. How can we actually engineer and harness the power of these pre-existing networks? How can we harvest their power and, in a sense, manipulate them in order to induce the spread of positive behaviors? Now, the spread of behaviors is important, but the limitation of the Harvard studies that I mentioned that show sort of this contagious viral spread is that it's important to disaggregate the distinction between induction, which is that John gets Jim or John gets Jane to go to the gym, and therefore John is the causal factor in weight loss in Jane or Jim. Okay? So the causal relationship. So if you have a medicine, the ingredients in the medicine are causally related to hopefully an improvement in one's health. The second thing is oftentimes called reverse causation or homophily, which is how do we actually know that the causal relationship is working in that direction? How do we know that John and Jim didn't become friends because of some external factor, like the fact that, or Jane and Jen, like the fact that both of them happen to be very physically active, and in fact, the physical characteristics in reverse are causing the friendship. They both met at the gym, for example. And then confounding. And the confounding factors could be other issues like genetics, something unrelated. And so what we tried to show with our study, which I'm going to talk about in a few minutes, is not only that there is a causal relationship between the social networks, the social relationships, and health improvements, but exactly how this causal relationship works, and what are sort of the ingredients, if we use the analogy of a pill, what are some of the ingredients that we might think about, and how do we think about optimizing these ingredients if we want to continue to not only induce behavior change and induce improved outcomes, but also to sustain them in the long term. So some of the previous studies that we had looked at did not address the causal relationship, and they did not disentangle the types of social network clustering that cause the spread of, or the observed spread of obesity or smoking behaviors or alcoholism and so forth. So let me talk a little bit about the microclinic philosophy. So this is what I came to call this model. And the word microclinic is really meant to signify that in many ways the most important aspect of a health system, of a public health system especially, is the people. It's the people and their relationships with one another. In a sense that social network is the first line of defense that keeps people unnecessarily out of hospitals, out of emergency rooms, out of major surgeries. And this is done through behavior change and through prevention. So the basic philosophy is as follows, and by the way, this is part of our curriculum. We teach our patients that we interact with about the ways in which they're influenced and they influence others. So chronic disease like diabetes is or HIV can be biologically infectious or non-infectious. But the behaviors that drive these epidemics are, in fact, spread through social networks. They're socially contagious. If bad behaviors can be spread, then so can good behaviors. So we actually teach our microclinic participants this simple concept. Now, I'm going to get into sort of the curriculum and the program in a bit, but I just kind of want to address the educational component of the program. So there's the sociological education, and then there's kind of, okay, what is actually taught. So what is taught kind of falls into 4 basic categories that everyone can remember, and in fact, when they go home, they can teach their kids. So meals, movement, monitoring, medication, 4 M's. So we place these 4 M's within the context of the social theory that I just explained to you. So how do people affect my meals that I eat? How do I affect the meals that they eat? Think about your children. Think about your husband. Think about your wife. Think about your neighbor who eats dinner with you every night because she's also your cousin. Monitoring. How do other people affect how you monitor? Self-monitoring. Taking your blood pressure, taking your blood sugar, perhaps going to the doctor. Does anyone go with you to the doctor? How do you impact other people around you? Your children, your family members, members of your religious community. Movement, right? This is the one about getting active, going for walks. Many of the people in our program start to walk together. Some didn't know each other, some did know each other. But going for walks together, doing other activities, and conversely, not doing things together that, watching TV together, right? That's still a social activity, but we would rather that instead of doing that they're actually physically active. And of course, medication. Are you adhering to the medication prescribed to you? Are you communicating with your doctor? One of the things that we hear constantly is that many people just feel very disempowered. It's like a revolving door. They walk into a doctor's office, they leave with some pills, they don't really know what they're for, they don't know how they interact with other things, and that's it. Maybe they take them properly, maybe they don't. This also applies to insulin injections, taking them in your leg, or so many other things. And I just want to make this point that many of the places we work in, because they are very economically disadvantaged communities, there are many theories about what diabetes is, and many theories, and theories is often a generous word, about what to do about diabetes. For example, I'll give you a case from the Middle East. One elderly lady used her life savings, several $1,000s, to travel to Syria. This was before the Civil War, and she had a surgery where somebody told her that he was going to remove lymph nodes from her feet. And so she showed me these huge scars on her feet, and this was supposedly going to cure her. And of course, it didn't. So these 4 M's are really an important first step in giving people a package of information that they can learn, they can memorize, and they can propagate through their network. The social theory is something that helps them understand what's happening to them. Why are we continuing to drink soda as a family? You know, and how can I fight against this? When my husband complains after I get rid of this Coca-Cola, and by the way, it helps if the husband does come to the program. Okay, so you start with an individual. They recruit a group, friends and family, pre-existing network that's being harvested. This program is done, by the way, in collaboration with a local health system, like a local clinic or something. And then those groups learn the 4 M's together, they learn the social theory, and then they go back into their society, they go back into their homes, they go back into their places of worship, their community centers, their women's clubs, and they go with commission that they need to help others to change. So in political science terms, this is called, changing norms. And in order to change norms, you kind of have to have this tipping point when enough people in society sort of make it socially unacceptable to do certain things. In the same way that in many parts of the United States, it's now socially unacceptable to smoke cigarettes. But that took time. It took normative change. So microclinics are groups of family and friends who come together into these groups. They're nested within classes, and these classes take place at neighborhood community centers, health centers, and the program strengthens social interaction and encourages the sharing of health information. I'm going to talk today more about a trial that we launched in rural Appalachia, Kentucky. I'll just say that this model initially started in the Middle East, and we did some studies there, including an RCT, which is currently in the review process. And we saw that this was really working, and so it was picked up by the government, and they sort of implemented it at a national level. They integrated it in their Healthy Community Clinic program, and also the United Nations picked it up and implemented it at a regional level for refugees. Now, before we came to Kentucky, a lot of people said, well, what you're saying makes a lot of sense, especially in a highly social culture like, Middle Eastern society, Jordanian culture. That makes a lot of sense. People still live together. But the United States is all about individualism. People like their independence, their liberty. Tocqueville wrote a book about it. We don't think that the same principles translate necessarily. And, I think there's something to that. Not everything translates from site A to site B, but what we're sort of getting at is something that is inherently human. The idea that we all need people around us, and we all have people around us who change the way we think, the way we dress, the way we act, the sort of music we listen to, the sort of food we eat. Everything about our social behavior is influenced by others. And some of us are more influenced by others, and some of us influence others more. But that interaction is a universal principle. So we were invited into this community, and there's a healthcare company called Humana. Many of you have heard of them. And they were interested in understanding if it was possible to sort of reduce chronic disease in areas that they care about, that they're headquartered in Kentucky. And so we sort of said, well, our interest is in working with anybody, for-profit corporations, non-profit corporations, state governments, private foundations, charitable foundations, because we think that everybody needs to be at this table in order to sort of deal with this problem and to align the incentives. In this case, it makes sense that a health insurance company loses money when people get sick. They have to pay hospital bills. That's sort of a no-brainer. And so we shared a little bit about the work that we've been doing in the Middle East, and they agreed to support this. Our other partner was the local public health departments. Now, unlike the Middle East, highly urbanized, there's refugees, Middle Eastern culture, different religions, minority Christian religion, majority Islamic faith. This is the Bible Belt. It's white, rural Kentucky. Not very urbanized at all. We're in a place where many people get their food from gas stations. There are large Walmarts. There's a lot of health misinformation, an enormous drug epidemic, extreme rates of unemployment. When one goes to Appalachia, Kentucky, coming from the Bay Area, it's as if one is going to a totally different country. At least that's the feeling I get. So we did a randomized trial of the microclinic intervention, which was about 9 to 10 months, and with follow-up. We did a 2-arm trial, one arm receiving the microclinic intervention, which I just described, the other not receiving any intervention. And participants were to enroll largely as pre-existing networks of friends and family members. Here's a bit about randomization tree. And we formally enrolled in the intervention about 300 people and 193 in the control group. This is sort of a way to conceptualize trial and the way it's multi-layered and nested into different groups, smaller and smaller groups, with microclinic clusters at the bottom. And here again, the distinction between the intervention and the control. Now, most of the participants in our trial, not only in Kentucky, but also the trial in Jordan that we did, which perhaps I'll be able to share another time, were women. And this is largely due to a few reasons. First of all, it seems that women in the communities that we worked in tend to take a little bit more of an interest in their health and in their family's health. Secondly, especially in these communities, they're for example, in Jordan, we tended to see some more traditional family roles where men were the breadwinners and women were, as I like to say, working more than a full-time job, dealing with many household matters, including child care, grandchild care, and great-grandchild care. And we see some of these similar characteristics also in Appalachia, Kentucky. I want to walk through a little bit of the program, just to give you a sense. Some of you mentioned the diabetes prevention program, and you'll see that in our program we try to kind of make it fun. We try to make it a little bit of a social activity, not just a kind of tedious lecture. It's interactive, and these different modules that you see really kind of fit into the buckets of meals, movement, monitoring, medication. I want to draw your attention to the red part of the screen, the red font, which are open community program sessions. And the reason why this is important is because we're working in a small community, and during the winter months, it became very, very cold, snowy, difficult for people to get out of their houses. And so we were kind of faced with this dilemma, which is, do we let the program go cold, no pun intended, for a few months, or do we try to do some things to kind of keep it active during the winter snowy months when everything kind of really comes to a halt in Bell County. So we decided on kind of creating community activities in order to kind of get people out of their houses and get as many people as possible in order to really keep the program up and running, and not to let people lose interest. The reason why it's relevant, of course, is because we're running a trial that is not comparing this medication to a sugar pill. We're measuring the impact of social networks and education, interventions that are inherently what? Socially contagious. So there's a danger from a scientific perspective that the ideas, the education, the support, the normative change in Arm A will contaminate the control group, which is Arm B. And this is not something that we would have to worry about in a trial where we're measuring a drug against placebo. So the results are impressive and the results I'm presenting here are from phase 1. Phase 2 results are under review, and there's also a crossover dimension to them, which I can explain perhaps at a later time. But the results you see today, I think, are very interesting precisely because there was likely cross-contamination, especially at these events that are highlighted in red. Contamination of ideas in a positive sense from the intervention arm to the control arm. So this just gives you a little bit of a picture of some of the dynamics of the program, and kind of here we have picture 2 healthcare workers from the local health department. In order to facilitate this program, one does not need fancy degrees, advanced education. It's really just about kind of taking these simple concepts that we want people to share with their own friends and family, and making them simple enough that they can propagate from a facilitator to a group like this, and that a group like this can then turn around and take those same concepts back home. So the results from this study are very interesting, and they'll be interesting to compare when the full results from this study and our other studies come out. This study in particular was not focused on diabetes specifically. It was more about addressing weight loss, and of course associated with it, type 2 diabetes and cardiovascular health. Our program in Jordan is more specifically focused on diabetes. And this was just due to kind of the feedback given to us by local communities. Whenever we go into a community and kind of bring this model, it's something that we do in consultation with local experts, and we kind of ask them to help shape what we're going to be doing in their community and what their interests are and what their priorities and needs are. So we see here that weight loss was not only achieved, but also sustained even to the 67 to 69 week interval. Similarly, waist circumference was achieved and sustained, although you could see that it was attenuated towards the end. Blood pressure. Cholesterol. A1C, and here we can see again towards the end of the program some of the gains were attenuated, some of the improvements. And we also asked some questions via questionnaire about physical activity. So, to sort of better understand the mechanism by which individuals reduce their weight and improve their blood pressure and so on. And as you can see, there's an improvement in among participants in the intervention group in terms of increasing their vigorous activities. And just anecdotally, this might be observed from the fact that one of our program participants got a bunch of her neighbors to go walking, and she not only lost a lot of weight, but she got other people around her to lose weight. And in this small community, those sorts of behaviors and examples tend to spread around. Increase in aerobic activity. So one of the things, if you recall from the menu of activities, was to actually do some collective exercise classes. Let's see, do we have a picture? So, some people brought in kind of a Roomba instructor, and they brought them to the class and sort of did a session. Sorry, not Roomba, Zumba. Roomba.
Got some clean floors.
Yeah. My wife is making me use the Roomba as we prepare for the baby to come, so my mind is sort of set in that mode. Increase in swimming activity as well. There's some local community pools. Yes?
I have a quick question. Just all of these activities that you mentioned seem very positively framed, like community, getting people involved. And one thing you let out with was behavioral economics, the idea that sometimes there's peer pressure,
Yeah.
or maybe. So I wondered about commitment, how do people stay committed to one another in this program? Is there any facilitation about commitment? Like getting people's shared commitment to do this? Or is it just sort of oh, we all feel this is good and we're gonna implicitly do this? Or is there an explicit commitment that people are making and together?
Yeah, no, I mean that's sort of a key question, right? Because the idea that we all influence each other is obvious, I think, to most people, right? But Hector is sort of nailing it on the head, which is, what are the specific mechanisms that are involved in people influencing each other? What are the sort of the psychosocial elements of it? And once we identify those pieces, sort of how can we augment them? How can we break things up into smaller and smaller levels of detail, and isolate those things that are